Good evening, everyone. I'm Neil Love from Research to Practice, and welcome to Questions from the Community, as our faculty today will discuss available research guiding the care of patients with relapsed refractory myeloma. We have a great faculty today, Dr. Ajay Nooka from the Winship Cancer Institute at Emory University School of Medicine in Atlanta, and Dr. Paul Richardson from the Dana-Farber Cancer Institute in Boston. We're here today to talk about myeloma, and as in all of our programs, we will be discussing the use of agents that are not approved. So please refer to prescribing information for specific information for each product. Here's where we're heading. We're going to start out just chatting a little bit about what happened at ASCO, and then we're going to go back and forth between presentations and showing you some questions from a survey that we did of general medical oncologists. We asked 50 general medical oncologists, what would you like to ask the faculty during this myeloma program? Well, I went through all these, picked out the ones that were most common, and we'll give you some samples as we go here today. But before we kind of get started, I just want to take a breath and reflect back on a couple of things that happened outside of myeloma. I'm kind of curious whether you see any analogies to some of the strategies going on within myeloma. And first, in yesterday's plenary session, we saw much anticipated the first adjuvant trial of immunotherapy of a checkpoint inhibitor with MSI-high disease, in this case atezolizumab, showing a significant hazard rate of 0.5 improvement. Didn't have an arm that had immunotherapy alone. A lot of people think that would have been just as well, but at least we finally have a trial showing that in this specific population. Last night in our GYN meeting, we actually had a case presented of a patient with a POLE mutant disease, but even more sensitive to immunotherapy. The patient had been on checkpoint inhibitors for 5 years. So targeted therapy for immunotherapy. And then again, in the breast cancer session, we saw the SERENA-6 trial. It was in the New York Times this morning. Basically, patients on first-line therapy for metastatic disease were monitored for the development of a mutation resistance, ESR1 mutations, and those patients, even though they were stable clinically, were treated with a different form of hormonal therapy, a SERD, and again, impressive results, 0.44 hazard rates. Seems like it's not pretty likely to go into practice. And finally, this morning, a presentation we were really looking forward to in breast cancer. And believe me, tonight with Hope Rugo and Al Burstein, your colleague at Dana-Farber, Paul, I guarantee you we'll be talking a lot about Destiny Breast 09. The use of an antibody drug conjugate in first-line therapy, trastuzumab deruxtecan, compared to what has been the standard chemotherapy with pertuzumab, trastuzumab, hazard rate 0.56, no big surprise. This drug clearly works well. Downside, of course, with this, you see interstitial lung disease. They actually had 2 grade 5 events out of 383 patients. But again, antibody drug conjugates in first-line therapy, even in hematologic cancers. We see that now with diffuse large B-cell lymphoma, polatuzumab, R-CHIP. We see it in urothelial bladder cancer and enfortumab vedotin and pembrolizumab. And my question to you is, when we start talking about belantamab, you think the day might come that ADCs will be part of first-line therapy, and we're going to get into that today. But just to take a step back, Ajay, I know these are all solid tumors, but I'm curious what your perspective is on some of the strategies that we saw here.
Thanks, Neil. The best analogy that I can think about is the risk stratification. So if you think about where the mismatch repair, the cancers were treated quite differently with significant improvement. So this, I would say, I would put the analogy as a high-risk cancer or the standard risk patients, how to move them, how to separate them, and try to treat them with intensive therapy or less intensive therapy, depending on the risk. So that's the best analogy that I can think of. And there are more trials that are developed in this space exactly asking that specific question.
Yeah,
I would agree. Thoughts?
Well, yeah, I absolutely agree with Ajay that this tailored approach that's risk adapted makes great sense, and we'll touch on that a little bit more in a moment, I think. But I wanted to pivot back to your point about antibody drug conjugates, Neil. I think you're absolutely right. Belantamab mafodotin, cut to the chase, Bella is back. And I want to show to you today and our audience just how important we think the data is that we're going to share with you, pointing to the fact that we need kind of all hands to the pumps. Whilst we've had great success with bispecifics and CAR-T, we've recognized immune exhaustion, we've recognized the challenges of real-world practice and true off-the-shelf capability. And belantamab mafodotin, not a moment too late or too soon, in my opinion, has shown real benefit in combination, and we'll touch on that again. So to see the breast cancer story emerging so positively resonates certainly with me.
And actually, now that I think about it, at this ASCO, we also saw first-line ADC and triple-negative breast cancer, the antibody-drug conjugate to TROP2, sacituzumab govitecan. Again, probably going to become first-line therapy for triple-negative disease. So ADCs are on their way. All right, so again, we're going to really focus on relapse disease, but we had to bring up the issue of upfront treatment. Again, this is the survey that we just completed over the last couple of weeks. I thought this was, kind of interesting comment. Myeloma is so complicated now. Well, to me, it's always been complicated, but I have to agree, there's no way you can cover it in an hour, and that's why we're just picking out a few things to talk about tonight. So I guess one thing about upfront treatment, Ajay, is should all patients be getting anti-CD38 antibodies? Now we have two. At this ASCO meeting, we saw data on the on-body sub-Q device for ESA. It's going to be really interesting to see how that evolves. Are there situations where you don't use either ESA or DARA up front, Ajay? And any comments about what's going to happen once ESA is sub-Q?
Yep. This is a great question. So we had seen over the last 10 years, Neil, so what we had seen was the improvement in the response rates, the depth of response rates with the triplets, started with the doublets, the triplets, and the quadruplets. The quadruplets giving us such good depths of responses that we started to not only use in the transplant-eligible patients, now we started to use in the transplant-ineligible patient population. So now, which is the best CD38 antibody to use in this specific setting? We have data for both the isatuximab as well as daratumumab. And just to give a flavor of what can be expected from a PFS standpoint, not even an overall survival standpoint, this is a disease where we were used to seeing 3-year survival rates. Now, just with a quadruplet in the Perseus trial, the expected median PFS is close to 15 years. So the whole landscape has changed. So in my opinion, unless you find a strong contraindication, everybody should get a CD38 antibody in the upfront setting, a quadruplet, if the patient can get.
Yes, I would
Paul,
agree, Neil. Sorry. Yeah, Neil, please.
Paul, another thing I want to ask you about, because we're going to kind of jump around here and just get your take on some of these things, of course, was the big daratumumab presentation at the last ASH meeting on smoldering myeloma. A lot of questions about that, Paul. We could spend 15 minutes or an hour even talking about smoldering disease. But bottom line, are the data compelling enough for you to want to use daratumumab or any other therapy for smoldering disease?
Well, I think in high risk for sure. And I just want to echo a point that Ajay made so nicely about the quadruplets. I mean, they're transformative in terms of PFS, but in the transplant ineligible population, those who have traditionally been a very much more challenging population, we're seeing quadruplets generate median PFSs, approaching 8 to 9 to 10 years with just the quads alone. And that, I think, in itself is a remarkable milestone. And I think in the smoldering space, to have the ability to deploy daratumumab safely in a high-risk population and see survival benefit in the Aquila study, I think is really encouraging. And so I think we've entered a whole new era of antibody-driven strategies where, in particular, targeting CD38 either with daratumumab or isatuximab is showing real benefit. And one side point here to Ajay's point earlier about targeted or tailored therapy, we're really seeing that in the 1Q amplified population, which is up to 40% of newly diagnosed myeloma, there may be some differences in which there may be more benefit from isatuximab compared to daratumumab, although those differences do not appear to be marked. So we want to be careful. But I do think we've got a really exciting new time with both CD38 antibodies available to us.
So, Ajay, any comments about smoldering disease? We've seen trials in lenalidomide, we've seen RVD, and now we're seeing DARA. right now? In what situations do you want to employ therapy, if any, and which therapy?
Neil, the biggest challenge is you're asking the right question. So who is that right person that needs the treatment? Yes, all the interventions that we had seen have helped to the hazard ratios of 0.29 with the lenalidomide-based lenalidomide-based therapies and 0.5 with daratumumab. So there is no doubt that there's an intervention with the primary endpoint of delaying the progression. The interventions are helpful. The biggest challenge comes here to identify the right patient that needed to be treated with. So the Mayo Clinic 2-20-20 risk stratification is probably where we can go with. We can all agree that if somebody has 2 or higher risk stratifiers in terms of paraprotein of greater than 2 gram per deciliter, free light chain ratio of greater than 20, and a bone marrow plasma cell percentage of greater than 20, if somebody has all 3 or more than 2, their risk of progression is within the 2-year time frame. The only caveat I would say is in evolving paraprotein, if you're seeing somebody hits these criteria and they're evolving, those are the patients that in my clinical practice, I would certainly start to act on.
Yeah, completely agree.
So, and which therapy, Ajay?
So daratumumab, it's a finite period of therapy for 3 years or 39 cycles, has shown, as Paul was saying, an overall survival advantage where 92% of the patients were alive at the 6-year mark compared to 86% of the observation arm. It's almost a 7% survival improvement that you're seeing with a very, very short window of 6 years. So I'll be favoring daratumumab. And the second option is lenalidomide. And with lenalidomide, the best benefit from the ECOG study as well as a QuadRx trial is the therapy given within the first 2 years. So if I'm using it, I'm not going to use it indefinitely. I'm only going to use it for 2 years.
So I want to move on now, and we're going to have Paul present some slides and data. And Paul, I was just kind of reflecting back when I first started working with you. You were part of a group bringing RVD to practice, and wow, that was such a gigantic change for this disease. Then we had the anti-CD38 antibodies come along, another big bump. Then we had CAR T, another exciting bump. Then bispecific. So everybody's getting more and more things on board, more and more confused. And then all of a sudden, ADCs show up again, antibody drug conjugates. Well, I'm curious where you see that fitting in. But let's just talk about the data right now. So take it away, Paul.
Thank you, Neil. So really a pleasure to be here, everyone. And I just wanted to echo the point that Neil made so nicely and echoed also by Ajay. Lots of options. And I'm going to focus on belantamab, mafodotin, and belantamab as antibody drug conjugates, and in that, or the naked antibody in the case of belantamab, and then, if time allows, pivot to the CELMoD story. I think what's very important is that as a BCMA-targeted antibody drug conjugate, belantamab mafodotin is our first in class and the first improved in 2020. Unfortunately, the DREAMM-3 study had some kinks in it, and as a result of that, whilst it showed an encouraging DOR, which we'll come to in a minute, it didn't meet its primary endpoint of PFS. But I want to bring your attention to some of the mechanisms of action of the antibody drug conjugates. The fundamental message is they're profoundly immunogenic, and what they generate is a highly targeted approach driven by the BCMA target to deliver a cytotoxic warhead. And in that regard, there's important advantages over bispecifics and CAR Ts, at least in theory, not least of which based upon immune exhaustion. Now, in that context, the initial approval was led by Saga-Sagalonial, and it was a privilege to be part of this trial, the DREAMM-2 trial, in which we were able to establish from monotherapy, essentially, of belantamab mafodotin in a heavily pretreated population, a highly consistent response rate, a decent DOR, and a PFS that was adequate to get the accelerated approval category filled. We also did a lyophilized presentation cohort, small number of patients here, but again, response signal very respectable at 52% and encouraging PFS as well as DOR and median overall survival. And real-world data certainly has matched that. Now, when the first study of the randomized setting of DREAMM-3 came in, comparing belantamab mafodotin to pomalidomide and dexamethasone as third-line therapy, the challenge was that the PFS, whilst different and in favor of belantamab, did not achieve this level of significance that was needed. But I would bring your attention to the DOR of 77% 1 year for those who responded versus just 48% for the control arm. So that, in a way, was the signal. And then when you started to combine belantamab mafodotin with other drugs, such as in this case in the DREAM6 study, lenalidomide and dexamethasone, and then most importantly in a cohort which Ajay was part of, which was the combination of belantamab combined with bortezomib, I just want to bring your attention to the response rate at 78% in this study, which I think was an important clue as to what was coming. So DREAM7 arrived and was published last year. I want to especially acknowledge the investigators led by Dr. Vania Hongrea. And what you can see here is a striking PFS advantage against a daratumumab-based control arm. Dara VD, clearly an active control compared to belantamab VD. And there you can see a hazard ratio in favor of the triplet with the antibody drug conjugate of 0.41. And I think this is incredibly important because not only did we see this PFS benefit, but with an updated analysis that Vania presented at ASH in December last year, you see a striking survival advantage with overall survival generating a hazard ratio of 0.58 in favor of belantamab mafodotin combined with bortezomib and dexamethasone over the DARA-based combination. And again, this immunogenic signal clearly being the key part. Now, excuse me, not to be outdone, but MRD was a very important part of these trials, and I just want to emphasize striking benefits not only in response rate, but also in MRD negativity in favor of the belantamab-containing combinations with a manageable side effect profile. Now, the ocular toxicities are real, but very, very importantly, the rest of the toxicity is exquisitely manageable, as is indeed the ocular toxicity, which we'll come to in a minute. And then if you looked at PFS in patients by MRD status, there was a very consistent signal. And if you achieved CR with MRD negativity with belantamab-based therapy, the median PFS was over 2 years compared to 1 year for control, which I think is very important. And at this meeting, Mariví has presented some very nice data looking at high risk, which again gets to Ajay's point earlier. If you look in a risk stratified way, you can see here that the belantamab mafodotin combination combined with bortezomib dexamethasone was exquisitely active in high risk disease with a median PFS of 33 months seen in this subset analysis, which I think was particularly important. Similarly, you touched on upfront therapies or earlier use. Just worth mentioning that belantamab is moving earlier, and in that context, the combination of Bela RVD in early relapse is very active. In that same context, DREAM8, which was led by Thanos Dimopoulos and others, combining belantamab with POM-DEX compared to POM-VD as an adequate control, showed a striking hazard ratio in favor of the belantamab POM-DEX combo with a hazard ratio of 0.52. This was very interesting, I think, because if you looked then at MRD, really the differences were quite remarkable. MRD negativity for POM-VELDEX, which is an active control, well tolerated generally and certainly widely used, the MRD negative rate was just 5%. In contrast, the MRD negative rate for the use of belantamab combined with POM-DEX was striking, in my opinion, at 32%. And again, a manageable tolerability profile. What about high risk? Well, again, here, this was really, I think, very interesting. In the high risk group, the median progression-free survival for the belantamab-containing combination was 21 months compared to just 9 months for the control. So again, a striking difference in favor of the belantamab-containing combination. And outcomes by MRD status, well, no surprises here, but if you achieve MRD negativity, median progression-free survival has not been reached. And I think that's really very exciting and points to the value of these platforms. This obviously all resonates on the Algonquin trial led by Suzanne Trudel, which has shown a median PFS of 22 months for the combination of belantamab POM-DEX with a median overall survival approaching 3 years. And then a couple of other last quick points. Belantamab combined with other drugs is proving very exciting and active with a highly consistent signal. And then finally at this ASCO meeting, there's been the belantamab naked antibody experience, no corneal events of note, and very interestingly, a response rate pointing to the value of this going up front. Now, or rather being used in combination. Now, what about belantamab and ocular toxicity? Well, the important news here is this has proven much more manageable than was initially thought of. And to cut to the chase, essentially from a patient standpoint with dose and schedule change, this becomes much more manageable and much less of an issue. And at EHA, our team, which is led by Evangelos Terpos, will be presenting a clinical management of belantamab mafodotin associated ocular events with practical guidance from an expert experience program. Now, in the last couple of minutes, I want to finish by touching on the CELMoDs. I think it's important to remind everyone that targeting cereblon, of course, has been the platform for the success of immunomodulatory treatment, and protein degradation underpins this process. Mezigdomide, which has been a privilege to be part of the investigative team for, together with also iberdomide, are in a different class, in my opinion, to the classic immunomodulatory drugs. They're much more potent. And in this regard, they're able to degrade substrate that much more actively and strikingly. And they close the cerebral E3 ligase complex dramatically, with iberdomide doing so by 50%, mezigdomide by 100%, and pomalidomide in contrast by 20%. Now, this effect results in dramatic properties pharmacodynamically, and this is summarized here. The other thing that's really important to understand is there's an intriguing observation that there's a substantially decreased risk of second malignancy from the CELMoD compounds, from both iberdomide and mezigdomide, in contrast to lenalidomide. So with this striking panel of preclinical activities so demonstrated by a whole series of elegant experiments, translating this to the clinic has been really a joy. Mezigdomide first, this has just been shown as an oral combination to be highly active in heavily pretreated disease, with a response rate of 41% and an overall response rate in BCMA-treated patients of 50%, just for the oral combination of mezigdomide and dex. And an striking example of this is my patient here, who unfortunately was much challenged by extramedullary disease. And as you can see, in the context of 4 months of mezigdomide and dexamethasone therapy, he enjoyed a complete response to treatment. And this particular drug is actually designed to target EMD. The excitement really grows when you combine mezigdomide with other drugs, be they proteasome inhibitors or in that regard, both bortezomib and carfilzomib, response rates are going as high as 80%. And if you combine mezigdomide with monoclonal antibodies, the story is even or as exciting, with response rates of 75% with DARA, somewhat lower for elotuzumab in DARA-exposed patients. And then finally, when you combine mezigdomide with other novel agents, such as tazemetostat and indeed trametinib, even in very heavily pretreated patients in whom, unfortunately, BCMA-targeted approaches have failed them, including CAR-T, we're seeing really encouraging results. And it's been a privilege to be part of this study with Luciano Costa as our PI, with response rates of no less than 75% in these heavily pretreated patients. Now, what about iberdomide? Iberdomide has been really equally a pleasure to work with, this work led by Saga. And as you can see, the combination of iberdomide, first with dexamethasone and then with other drugs, has been remarkable. And I just bring your attention to the combination of iberdomide combined with bortezomib and dexamethasone at 100%. And then when you put into earlier relapse these combinations, they've performed exceptionally well. And with that in mind, there are a number of studies that are showing other combinations are equally promising for this highly convenient all-oral approach. And at the ASCO meeting, there's been a very nice presentation from Dr. Lashokin from the Memorial Sloan Kettering Cancer Center team of ELRA combined with iberdomide in relapsed refractory disease, the so-called Magnetism MM30 study, which is getting underway, and we're excited to see that. The phase 3 studies of CELMoDs in relapsed refractory myeloma include Successor-1 and Successor-2. It's been great to see Excalibur fully enroll. That's the iberdomide study. And it's also great to see Successor-1 and Successor-2 doing extremely well, with Successor-2 near to completing its enrollment and Successor-1 not far behind. So in conclusion, I really wanted to emphasize that we think belantamab is back. Belantamab mafodotin is really, I think, an important potential treatment option for our relapsed patients. And obviously, we're looking forward to regulatory approval to really establish its value. I think in the same context, the CELMoDs have real importance and real-world value as oral agents combined with other backbone agents to improve outcome. And in that context, we have an increasingly busy novel therapeutic landscape, but I would argue that we need all hands to the pumps. And in immune-exhausted older patients, for example, these agents are invaluable. And thank you very much for your attention. Thank you, Neil.
So, wow, that was amazing to go through that, and so understandable. I was just flashing on the fact there was a medical oncologist contacted us and said, I listen to your podcast every day on the way to work, half an hour back, but he listens at double speed. And I was just imagining him listening to that last 10 minutes at double speed. It was hard enough for my brain to comprehend it in real speed, but really a great review. Now let's talk about what are some of the questions that we been getting about these entities, but also I wanted to ask you and Ajay about this interesting trial, the DREAM-10 study, looking at belantamab with the Lendex versus Dara Lendex. When Paul presented the fact that, when comparing belantamab to Dara, one of the best, if not the best active agent in myeloma, hazard rate 0.5 or lower, Amazing. Any thoughts about this trial? And if it's positive, Ajay, like what are we going to do about it?
Neil, this is a beautiful study. The way that I put this is take the analogy from the Dream 7 that Paul presented. So data plus VD, always I'm a sucker for these control arms. So data plus VD is a beautiful control arm where the median PFS was 16 to 17 months. How did the control arm perform compared to what was expected of the control arm? That control arm had 14 months. So, which is beautiful, where you see a 3-time improvement in the PFS with the data plus, with belantamab plus bortezomib and dexamethasone. So let's bring the analogy to the upfront setting. DRD, daratumumab lenalidomide from the MAIA trial, in overall survival of beyond the 7 to 8 year mark for transplant ineligible patients. You have to understand this specific study. 40% of the patients in this specific study were above the age of 80. So not only that they're reaching their life expectancy, they've done extremely well. In that specific patient population, if you're exchanging belantamab for daratumumab, what would be the benefit that one could expect in the frontline setting? The expected median overall survival in these patients were in their 80s, probably is in the range of 12 years, is what I heard. So looking forward to see how this pans out with a planned hazard ratio of 0.7, I guess.
So let's talk a little bit about some of the questions we're getting from oncologists about belantamab. What clinical scenario, like Paul, right now, if belantamab were freely available to you, in what situations would you use it? What combination or combinations would you be thinking about?
Well, I think I'm going to bounce off Ajay here and just say I couldn't agree more about this whole idea of, you've got Dara-RD a la MAIA up front. Then obviously if someone relapses in that setting, and that may be several years, hopefully, in an older transplant-ineligible patient based on the data, then think Bela VD, a perfect, safe, not cardiovascularly toxic, generally well-tolerated strategy could be ideal there. Or for that matter, Bela Pomdex, recognizing that in older patients, sometimes the IMiDs, aren't delivering in quite the same way as one might expect in their younger counterparts. That being said, you've got both choices to consider for a patient. And you can imagine here the value of belantamab, because if you can generate 3 or 4 years of disease control and you haven't actually hospitalized the patient, you've treated them with truly outpatient strategies throughout. For an older patient, you're looking at a 7 to 10 year horizon just with 2 lines of therapy. So this is kind of a lovely slide, actually, because you're really asking, I think, the key questions. The other question is, how do you dose Bela? Well, I think all of us are aware now that essentially, every 4 to 6, even to 8 to 12 week dosing works in individual patients. And you can start up front with a slightly more intensive schedule, in my experience, and then drop back. And you preserve response and you manage the ocular toxicity very favorably. And what's so exciting, Neil, is that we don't see CRS. We don't see significant infections. And actually, in my own practice, I frankly have never hospitalized a patient from a belantamab complication. And every patient I've treated, and it's now many over the years of Dream 1, Dream 2, and beyond, I have never seen ocular toxicity not prove reversible. So I think these are all incredibly important points to share with our community partners.
So Ajay, any comments again about where, again, if you had it right now, could use it anywhere you want, or where it would fit in? And also, in addition to Paul's scenario of the 80-year-old, what about the younger patient who would be eligible for CAR T and bispecifics? Where do you see belantamab fitting in there?
Absolutely. This is an evolving field. What we've seen here is the benefit of the combinations. So before I say who I would be using and how I would be using these patients, the Bela combos is I would not be using it as a single agent. A single agent Bela response rate is in the range of around 30%. You get a median PFS of close to 4 months. Not what I would be looking forward for. But if you start to combine with a AMID or a PI, even at a lower dose, and extend the interval between the dosings of Bela, that would be the most ideal scenario, providing a structure of how this should be given in the long run. I have an investigator-initiated trial using belantamab in the high-risk patients in the maintenance setting. Where we're using is we gave it every 2 months for the first two doses. then changed it to, it is 1.9 milligram per meter squared, then changed it to every 3 months. So literally the patient is coming to my clinic 4 times in a year if it's given every 3 months. Ocular toxicities are minimal. And none of the patients of the first 30 patients that 28 patients that we've accrued. So there is 0 progressions in these high-risk patients with Bella and Palm Index maintenance. So this is a highly active combo, and this could be extended and still be able to get that benefit. Always combine it with a partner rather than giving it as a single agent. Now, coming to how to use this in a younger patient population, the high-risk patient population, where we saw the significant benefit, both in the Dream 7 and Dream 9, Dream 7 and Dream 8, where the high-risk patient population got benefited significantly compared to the standard of care arm. So if I have to choose a specific regimen and a specific patient population in a younger patient population, those are the ones I would be certainly choosing.
So, Paul, we see here in the Dream 10 study, Bella versus anti-CD38 or daratumumab in this situation. You already have the quadruple therapy. What about adding it? Quintuplet.
Right. And that's a great question and a fascinating one. And the question would be sequencing and also that allowing to even further reduce your ocular tox because essentially you're sandwiching or you're syncopating with a CD38. I think at the same time as thinking of that, I think we also have to recognize Ajay's point about high risk and its use in maintenance, for example. So I think those are all very interesting questions. Personally, I think that the entity of immune exhaustion must not be underestimated. And what I'm impressed by is that belantamab doesn't appear to contribute to that. We have several lines of evidence for that coming from the trials. And I think that's very important, particularly in our older patients. But to your point, Neil, earlier, may also have real value as we think of sequence in our younger patients. So you don't burn a bridge for a bispecific, or you don't necessarily burn a bridge for a CAR T at a later date, where you may have some legitimate concerns that bringing something as powerful as cilta-cel too early into the game for a particular patient might carry with it unacceptable risk, given what we know about the toxicities. Belantamab, in contrast, may not bring that to the same issue to the table. So I think it just opens the door to further tailoring therapy for our patients, Neil. And I think I really like the way Ajay pivoted not just to older patients, which has kind of been my focus, but also to younger patients in whom one might think of this. And I personally have a patient in my practice who absolutely did not want to be hospitalized. He runs his own business. He's an electrician, younger man, and he's had almost 4 years now of benefit from belantamab and done remarkably well.
Yeah, the idea of maintenance sounds really interesting. And yeah, mentioning 4 years, we did a series a couple years ago where I did some video interviews with patients with myeloma, and I actually interviewed a patient who had been on belantamab for 4 years, just about the same time it got pulled off the market, which was kind of like, wow, why are we doing this? And I guess now we realize it's not an issue. So, Ajay, I don't have to tell you that the number one question we got about belantamab, and in addition to how to use it or where it's going to fit in, is the issue of ocular toxicity. It's something that is starting to creep into oncology. We're about to do a CME program on ophthalmic issues in oncology because you see this throughout oncology. ADCs, erdafitinib in bladder cancer, so many different agents now, but a lot of concerns about it. How are patients going to react to it? This one doc has his wife is an ophthalmologist. So, there's lots of questions and challenges. Can you use an optometrist instead of an ophthalmologist? Jay, can you give us a little granularity how this plays out? And also this delay of, giving between doses seems like it is very effective and very patient-friendly.
Absolutely. So we have to understand why is there a concern at the ophthalmic adverse event to be of a significant concern when grade 3 infections are so common with other bispecific antibodies. Eye is a very sensitive organ. Everybody gets affected, and we don't want to make anyone lose this sight. And what the DREAM trials have shown is all the toxicities are reversible. There's not even a single patient that lost the sight because of belantamab. I want to emphasize this very clearly before we talk about the strategies. So what is the toxicity in the eye? So it's all keratopathy. So it is all about how the stem cells migrate and how belantamab holds off and leads to the corneal ulceration as the worst side effect that anything can be possible. So if you divide them into the gradings, so grade 4 is the worst, and again, grade 1 is is something that people don't even feel, but yes, they can see it on a corneal exam. So now, how do we dose them? So when you're giving them every 3 weeks, absolutely, the grade 3 keratopathy was seen in 80% of the patients. So we know that's not the dose that we need to give. That's not the schedule that we need to give. That's where the extended interval comes into play. So how long can the interval be? So after the first 2 doses, everybody has this toxicity develop after the first 2 doses. So go with the first 2 doses, then extend the interval to even 2 months, because patients who are responding continue to have a good response. That's what Paul was talking about, the duration of response earlier in 70% of the patients, even in DREAM-3. So overall, an optometrist can do this. And the key here is the toxicity prior to the next dosing has to come down to less than grade 1 before you dose it. Otherwise, you're okay to skip off the dosing, and responses are preserved even if you skip the dosing. So very interesting drug. And the more that you use it, the more that you get comfortable with. And optometrists can exactly do this. And there's a scoring grade sheet or a grading sheet of what causes the toxicity and when the toxicity needs to go down.
So, Paul, we have got a bunch of questions about cell mods, in particular is when are we going to actually have them available, because we've been hearing about this for a long time. You went through the data very eloquently, but can you kind of summarize the bottom line of, sort of what the characteristics are of iberdomide versus mezigdomide versus lenalidomide and pomalidomide, and where you see in particular iberdomide and mezigdomide fitting in clinically?
Yeah, super question. They are distinct in my opinion. I mean, obviously they're both, both classes of drugs modulate the cerebral E3 ligase complex, but immunomodulatory drugs, or IMiDs, are far less active in this space and have a different molecular structure. So I think it's important to share that with everyone. The secret sauce lies in this closing of the cerebral E3 ligase complex. If you close it 50% or greater, which iberdomide does at 50, mezigdomide does at 100%, the targeted degradation of key transcription factors is stratospherically greater. And so as a result of that, basically these become degraders in the classic sense. And so mezigdomide is the most potent, and in the relapse refractory setting is also designed to penetrate extramedullary disease, which was the case I showed of my patient who had a really quite miraculous response. And the second point is that they are very well tolerated, and iberdomide shines in that regard. So I see personally iberdomide moving early or earlier in disease, and up front is obviously where we're looking to really excitingly study it, and as part of maintenance because it's so well tolerated. And 2, mezigdomide becomes the new kind of oral agent of choice in relapse, where it partners so powerfully with other classes of drug. Finally, and this is very important for iberdomide and to perhaps a lesser extent mezigdomide, the same oncogenic or second cancer signal that is generated uniquely by lenalidomide, valuable as that drug is not seen with either iberdomide or mezigdomide. So they really raise the promise of no second cancer risk, a more favorable tolerability profile, generally speaking, and much greater potency.
So we're going to move on now and let Ajay talk about more issues in the relapse refractory, mainly about, of course, what we get most questions about, bispecifics and CAR-T. And we've done 2-hour programs just on bispecifics in myeloma, so this is just a little tasting menu. But Jay, let's talk about some of the key data sets.
Thanks, Neil, for having me. So I'll be talking all about the cellular therapies, the CAR-Ts that are existing out there for myeloma, and who are the right patients that you can identify for the specific construct. And we'll be talking about the bispecific antibodies and where we have started and what are the key differences and where exactly we're heading. So the biggest question here there were some of these abstracts that were presented at ASCO talking about what are the key differences in terms of ide-cel versus cilta-cel. So from the KarMMa-1 trial, ide-cel was approved based on the median PFS of close to 9 months. from the CARTITUDE-2 trial, the cilta-cel was approved based on a median PFS of close to 3 years. So quite different patient populations that you can see. The real-world data sets are the ones that can help us to understand, is this the representative patient population that one can see, and what are the indications and how to use them in the different indications in this setting. So this in this specific analysis, they use the Trinetics global real-world data platform, where they identified a total of 485 patients that received the ide-cel and 392 patients that received the cilta-cel. They did a propensity matching for the demographics, the patient characteristics, the clinical characteristics, the disease characteristics, to identify an equal group of patients with 252 patients in each of these groups. So at a median follow-up of close to 14 months for the ide-cel and 8.5 months for cilta-cel, as cilta-cel was approved at a later date, what they looked for was the primary endpoint of time to next treatment as well as the overall survival. You have to understand the granularity with these real data sets or the real-world data sets that you can't find the PFS as you delineate in a clinical trial. So here what they saw was that time to next treatment was favoring cilta-cel, just as expected, with a hazard ratio of 0.6. And the overall survival was not reached. At the 2 years, it was 77% for IC versus for ide-cel versus 73% for cilta-cel. There's a lot of things that one can see here. Yes, cilta-cel is able to deliver that benefit in the long run in terms of delaying the treatment, the time to next treatment, but the overall survival has not been proven based on this real-world data set. There are other real-world data sets that one can see. This is a real-world data set based on those patients that had seen 4 prior lines of therapy. And this was the academic real-world data consortium led by Doris Hansen, where she got in close to 650 patients that received the IIT patient population. And what you see is the infused patient population is close to 550 patients. There is still an attrition rate of 9%, which clearly tells how to identify that specific patient population who would get benefited from a CAR T. So what you see here on the far lower right corner is the patients are the differences between both these constructs. Severe CRS greater than grade 2 is very common with cilta-cel. Delayed neurotoxicity, the odds ratio is almost 20 times. Infection is higher with cilta-cel. So the way that I look at this is the PFS, as we heard, that the PFS is significantly favoring cilta-cel, but there is that specific patient population, maybe no older patient population, where you don't want to take these risks. They're perfect candidates for ide-cel. So again, PFS and overall survival were favoring the cilta-cel. Yes, you get the bang for the buck, but the risk is higher as well. Moving on to the KarMMa-3 and the CARTITUDE-4 trials, where ide-cel and cilta-cel were evaluated in the early relapse setting. So, this is wonderful data that is presented by Surbhi Sidana for the different subsets of the CARTITUDE-4 trial, including the high-risk patients. First, let me look at the KarMMa-3 trial. So this is a patient population randomized to relapsed patient population of more than 4 prior lines of therapy, 2 to 4 prior lines of therapy, randomized to standard of care versus CAR T. It's a 2-to-1 randomization. There is a crossover on this specific one, so overall survival may not be the right endpoint here. Coming to the CARTITUDE-4, no crossover, and cilta-cel versus Dara-PD or PVD among patients with 1 to 3 prior lines of therapy. These patients were, again, early lines of therapy. And what you see with KarMMa-3 is a PFS benefit of 13.3 months versus 4.4 months. And with the CARTITUDE-4, the hazard ratio was 0.29, favoring the cilta-cel at a large follow-up of almost 3 years. And at the 3-year mark, 60% of the patients continue to be in remission. So when you look at the long-term outcomes, the overall survival is being favored with with cilta-cel versus the standard of care arm. When you start to look at when cilta-cel has such good benefit, even in the late relapse setting, you saw the data presented by Pete Voorhees showing that those patients on CARTITUDE-1, the overall survival was 5 years for them. So think about even 10 years ago, median overall survival is not even 5 years. In this patient population, overall survival from the time of CAR T receipt is 5 years, and a third of the patients still continue to remain in remission, probably the tail who we can call as a cure if the patients continue to do that over a long run. So what this also showed was in this specific analysis by Maria Matios, showing that if you give the CAR-T at an earlier stage, as well in CARTITUDE 4 versus CARTITUDE 1, those are the curves showing the benefit as an earlier line of therapy. So coming to what Surbi was presenting was how did the benefit extend between the standard of care arm versus the cilta-cel arm? And as you can see, the standard of care arm versus high risk, in every subset that is seen, the benefit favored the cilta-cel. So in the extramedullary patient population, the median PFS was 13 months versus 4 months with the standard of care arm. If you look at the lines of therapy, I'd like for you to look at the comparator arm. The standard of care arm had a median PFS of 17 months for one prior line of therapy, 12 months for 2 prior lines of therapy, 8 months for 3 prior lines of therapy. This is exactly what I would expect. And none of these median PFS was reached for the arm that received the cilta-cel. So extremely good data favoring cilta-cel in the early lines of therapy. Now, coming to the bispecific antibodies, we have 2 bispecifics targeting BCMA, teclistamab and elranatamab. Both of them were approved based on the MajesTEC-1 and the MagnetisM-3 studies. These are single-arm studies where the approval based on the EMA and the FDA differ, and these approvals for 3 prior lines of therapy in Europe and 4 prior lines of therapy in the US, and these are again approved, accelerated approval based on phase 2 study based on the overall response rates. The confirmatory trials are ongoing as we speak. There are a few key differences in this. MagnetisM-3 study had some extramedullary disease that is higher, which was in 31% of the patients versus 17% of the patients. Pentadrug refractory patients were higher in the MagnetisM-3 trial. And the studies had shown an overall response rate of 60% as a single agent with both these constructs. The median PFS for teclistamab was 11.5 months. Median PFS for elranatamab was 17.2 months. And what was presented here at ASCO is, if you look at the MagnetisM-3 study patient population that were enrolled in the US, there are 40% of the patients that were enrolled in the US, and look at the median PFS. This was 27 months that was presented, and the median overall survival was 43 months. This likely reflects our patient population, and this likely reflects the availability of treatments post-progression, and that's probably why you're seeing such improved benefits. Coming to the talquetamab trials, the Monumental-1 trial, there is an update at ASCO. For those of you that are aware, the Monumental-1 trial had 3 cohorts, the 0.4 milligram per kilogram given weekly, 0.8 milligram per kilogram given every other week, as well as a TCR prior T-cell redirecting therapy exposed group at 0.4 milligram or 0.8 milligrams. So the median follow-up of more than 30 months was what was presented here. And what you see is impressive across the board. The median PFS was 7.5 versus 11.2 versus 7.7 months, and the 36-month overall survival rates were significantly higher across all these 3 groups. The most common adverse events that one could see are the CRS of all grades were similar, 79% versus 72.4%. This is Q weekly versus Q other week. So what I want to stress on in the last minute is the GPRC5D associated adverse events. So there are 4 different adverse events that one can think about: taste-related, skin-related, nail-related, and rash-related. And these are all based on the expression of GPRC5D on these specific surfaces. These are on-target, off-desired side effects, as I put in. What I'd like to show you is the rates of discontinuation due to any of these adverse events. It is almost 0% across the group. So if only one can know how to give these drugs safely, you can derive all the benefit from this specific agent. There is one specific signal that was seen. This was ataxia that was seen in 1 patient in the Monumental-1. And likely there is some cerebellar expression of GPRC5D which could explain this ataxia. And that probably is why you see that adverse event. There is no other new deaths or any AEs related to talquetamab.
Wow, you both are great presenters. I mean, so much information in a short period of time. Let's take a look at some of the questions we got from oncologists about CAR-T and bispecifics. One, actually, we heard this. We did a program on non-Hodgkin lymphoma on Saturday night, and of course, there CAR-T bispecifics also. but the issue of, access to tertiary centers, particularly for CAR T therapy. Paul, any comments about whether bispecifics can be at some point administered by community-based oncologists? And also, Paul, we've kind of gone back and forth with CAR T. Initially, there was a lot of excitement. We kind of had just seen the diffuse large B-cell data looking like we're seeing cures with CAR T. We were hoping in the beginning that was what we were going to see in myeloma. Then it seemed like, from my point of view, listening to you all, then there was kind of some disappointment for a while. Now I'm hearing more talk about excitement, particularly with cilta-cel coming along, and even the cure word. So, Paul, any comment about the challenge of accessing CAR T therapy in tertiary centers in terms of access? And also, do you think we're moving in the direction of cure with CAR T?
Well, fabulous questions. I think access is actually key, and it's a major challenge. I think this is where bispecifics obviously offer a very important platform that has a greater ability to deploy in the community setting, in my opinion. I think very importantly, it's where the antibody drug conjugate space also has real value because it truly is off the shelf and community based. I do think CAR T, and certainly speaking to my own experience with my own patients, has been miraculous in some patients and remarkable. Soberingly, however, in my own real-world practice, I've encountered substantial toxicities and, very importantly, late Parkinson's in one patient whom I very sadly lost. So I think one has to be sort of very realistic and say it's amazing. Using it earlier, to Achay's point, I think is a very important new direction to go in. But I do think we need to work seriously to reduce toxicities because the real-world data, Achay, show about a 10% TRM, don't they? In our own group, we had a rash of HLH, which was lethal in 3 patients last year. So we've got to be a little bit careful. And I think when we think about CAR T, the new platforms to me, recognizing the incredible power of cilta-cel, the value of ide-cel, to me, some of the newer CAR Ts like anito-cel are really interesting because at the end of the day, they do appear, at least with the caveats of cross-trial comparisons, to be offering perhaps less toxicity, which I think is so important. And the flip then, and I think Achay did such a nice job of this, looking at the bispecific space, we're seeing really a much more convenient, much more patient-friendly strategies being developed where you can move to the outpatient setting and not have to hospitalize even with step-up dosing. And we're doing that on our own program. I think you have to be careful of, though, is, and especially from my own experience with bispecifics, is as you move into the real world and you treat much sicker patients because your sort of hand is forced, we still need to be very much aware of the side effects. And to Achay's point earlier, the reality of infections with bispecifics is absolutely there. And we see that as a major challenge. Conversely, we're seeing great results. So I think excitement, but with a healthy dose of caution around managing side effects.
So, audience, at the end of the slide deck, we have some papers we pulled out from both ASCO as well as EHA. I'm not sure we're going to get to them, but Ajay, one of the papers that we pulled out was from EHA looking at this other CAR T therapy, anito-cel, the Imagine studies. Can you talk a little bit about how it differs from, for example, cilta-cel? Also, your vision of, the pathophysiology of the neurologic issues with cilta-cel, why you see this Parkinsonian thing, and then what you see with this anito-cel and whether or not, this maybe in the future may be going to replace cilta-cel.
Yeah, great question. We're all struggling to understand the exact pathophysiology for the neurological toxicities. How anito-cel differs from the construct with cilta-cel or ide-cel, in fact, is it has a less off rate where you're expecting to see the engagement not to be as much. So I don't know whether that is purely the reason for why you see the differential toxicity, where you see lesser rates of neurological toxicity, significantly lesser rates of neurological toxicity compared to the existing ones, but thought to be one of the mechanisms. There are what makes it a good construct. Number one is it should be safe, it should be efficacious for all the given reasons. And comparatively, again, we cannot be doing cross-trial comparisons, but what is existing out there to what anito-cel was bringing in impressive response rates with impressive safety. That's what makes it a little more appealing so far. But as we go on to these large randomized phase 3 trials with anito-cel that are currently ongoing, we'll uncover more of these toxicities, whether they're real or not.
So, Paul, I don't have to tell you what the most common question we get about this, which is sequencing, and people who are eligible for both CAR T and bispecifics. So what comes first? I was kind of surprised how, the PFS with bispecifics is similar to what you see with CAR T. So how do you decide what comes first? Of course, CAR T has the incredible advantage of one and done. But in terms of PFS, how would you compare them? And how do you think about sequencing in different situations?
Well, I think it boils down to what I consider, efficacy. And efficacy is a function of activity and toxicity. So personally, I'm a big fan of bringing bispecifics earlier. I think that makes great sense to me. I'm a little bit more careful with CAR T only because I'd love to see the results of CARTITUDE 6 and CARTITUDE 5 to really inform that decision. But broadly speaking, I think the idea of the immunotherapies coming earlier in the treatment of myeloma makes great sense. But I am cautious about deploying a potentially toxic platform too early, because at the end of the day, as Ajay and I were discussing earlier, a quadruplet can gain you 7, 8, 9 years of disease control with minimal toxicity overall. A bispecific can prolong that even further, arguably, again, with manageable toxicity. And where belantamab belongs in all of that, we'll see. CAR T can be miraculous and fabulous. However, for a very small subset of patients, we can run into real difficulties that can be lethal. So all of these factors have to be thought through, I think, as we sequence treatments. The good news is we have multiple choices to pick from to tailor treatment for each of our patients.
So, AJ, what are some of the longer-term toxicities that you see, both with CAR T and then also bispecifics that a community-based general medical oncologist wants to be aware of, particularly the issue of infections, cytopenias, how you approach vaccination, preemptive antibiotics, both CAR T and bispecifics? I know that's a huge topic, but any specific pearls you want to share with us, Ajay?
Absolutely. I would have very less threshold to start antibiotic in somebody that's receiving bispecific or somebody that has received a CAR T. If you have to understand the target, the BCMA targeting agents really completely deplete the B cells. So if you can see that functional hypogammaglobulinemia, that lasts 6 months beyond you stop the BCMA targeting bispecific antibody, I would be giving IVIG through the course to minimize any risk of infections for these specific patients. So less threshold to start antibiotics, putting the patients, increasing the layers of security is how I look at it. Giving IVIG to everyone, giving neopogen, which is not a contraindication in any way in all these settings. And the CAR Ts, specifically, if there is an option for a stem cell boost, I would be proceeding with a stem cell boost after the first 6 months of time, where if the patient is not having recovery of their cytopenias. So the strategies need to be dynamic. You need to be starting to watch out for. And we have seen some of these viral reactivations similar to what we had seen in the post-allogeneic transplant space, because these are all T-cell defective patients that likely the viral reactivations tend to happen. So I routinely check for most of these viral reactivations on an ongoing basis, and holding off the drug, not starting the drug when the patient has an active infection is the most key. If there is one take-home point that I would need to convey, that's what I would go with.
So Ajay and Paul, this hour flew by. It was so interesting. I'm sure we could go on for another hour or so. Be safe, stay well, and have a great night. Thanks so much, Ajay. Thanks so much, Paul. Have a great night.
Pleasure, Neil. Thanks, everybody. Thank you very much.